Hello everyone and welcome back. Across the field of cardiac surgery, we have embraced transcatheter aortic valve implantation or replacement as a wonderful therapy for the right patient, particularly those of higher risk. But we've seen a creep in transcatheter aortic valve replacement or implantation in younger patients, oftentimes having premature structural valve degeneration. As we've been learning, robotic technology has the ability to decrease risk of morbidity. Now let's have a look at how to do a robotic TAVR explant and aortic valve replacement. One of the fastest growing operations performed in the United States is surgical explantation of a transcatheter aortic valve replacement device, or TAVR. Particularly in younger patients, premature structural valve degeneration that might require reintervention or explantation can be more common, and we are seeing more of that on a regular basis. As TAVR now extends into low-risk patients, remembering that the low-risk data is for older individuals. I'll present a case of a 67-year-old woman who underwent a 23mm balloon expandable transcatheter aortic valve replacement performed only 4 years previously at age 63, when she was considered low surgical risk at an outside facility and outside of guidelines. She presented in heart failure with severe structural valve degeneration, as well as type 3A and B mitral insufficiency. And on CT angiogram, she was found to have her left main coronary height, posing a risk for valve-in-valve therapy. And the patient had some physical challenges with osteoarthritis that multidisciplinary heart team assessment felt that minimally invasive approaches might be preferred. At this juncture, her STS predicted risk of mortality was 7.9% for both surgical TAVR explant and surgical aortic valve replacement and mitral valve replacements. As we can see by the echo, her ejection fraction had dropped to 35% from a previously known 55% with type 3A mitral insufficiency. You can see her TAVR prosthesis here with structural valve degeneration and premature stenosis. Size is noted. Intraoperatively, here's a robotic approach to her mitral. You can see there's evidence of rheumatic disease. A mitral valve replacement was performed as previously illustrated. And here is now the view. You can see the edge of the SAPIEN 3 prosthesis in the aorta. So the aortotomy needs to be a little higher. And for the residents and fellows that have not seen this type of procedure, this might illustrate sort of some techniques that one can utilize. Surgeons across the world are seeing this more commonly. We take the aortotomy down to the tops of the edge of the prosthesis. You can do an analysis, and you can see in only 4 years there's substantial structural valve degeneration, though the placement of the prosthesis seems to be adequate. This starts with very careful, sharp, and blunt dissection, and this is applicable both in open techniques, but now in this robotic case, you can see the principles. This is not to be manually just pulled out, as one can have issues with the subvalvular structures. It's slowly teased off of the prongs until we get down to the base of the felt strip that is common in this SAPIEN prostheses. The self-expanding prostheses are longer and requires slightly different techniques. The robotic arms are very strong, so you can then start to bend the edges of the SAPIEN prostheses in a circumferential way. And by so doing, it allows for continued blunt dissection and slow but meticulous movement to finish the blunt dissection, particularly at the level of the left ventricular outflow tract, and then this can slip out. And here's the TAVR prosthesis. You can see the severe structural valve degeneration at 4 years. And the valve is then delivered through the working port or incision. Now, this is important in that the valve has been somewhat plastered and actually somewhat remodeled to the aortic wall. So care must be taken to do a complete and thorough debridement, and this has to be done both sharply but also bluntly to carefully remove all calcific tissue. You can see the patient had likely a tricuspid stenosis, but it could have been bicuspid. It's hard to tell at this point. And then you can see that it's still peeled. We still have to peel off that last bit of calcium. Again, in order to get an excellent seating of the prosthesis, we have to make sure we have excellent debridement. Sutures are then placed, as we've shown previously. And circumferentially, you can see the integrity of the annulus is actually quite good. And in this rather small woman, we elected a 21 prosthesis. And we can seat this well. And here is the completed bioprosthetic RAVR with good clearance of the coronaries. And you can see the mitral prongs in nice position of the mitral bioprosthesis. And aortotomy closure. The patient was then delivered antegrade plegia to test the aorta. Sometimes the aorta can be somewhat friable in TAVR explants, but this one we were able to navigate quite nicely. And here's the echo result with a good and intact seated mitral prosthesis and aortic prosthesis with normal physiological gradients. The ejection fraction improved to 45%. The patient was reanimated without difficulty in normal sinus rhythm, without the need of epicardial pacing, and she made a full recovery and was discharged home on the 6th postoperative day. The case in its entirety has been published in the Annals of Thoracic Surgery.
So now we've seen how to do a robotic TAVR explant and aortic valve replacement. Join us in our next episode for another first, where we're going to talk about robotic aortic valve replacement and coronary bypass grafting.